So we're moving to our next power session, I guess. Yesterday we had the CEO of NHS England, Sir James Mackey, speaking with Roy Lilly, and we had a wonderful conversation, learned so much. We've got Michael Bell now chairing a session with the chair of NHS England, Penny Dash. Are they coming through? We'll just wait for them to come through. As a reminder, remember at lunchtime at 1 o'clock, Keith Grimes will be in here to talk to you about how do you get involved in health tech and how you take that journey. And there'll be a panel of 3 or 4 people helping you to understand that whole landscape. And Keith's been involved in the space for a long time. Do we have the speakers here? Do anybody know? Are they? Yes? So we'll just find out where they are. Hopefully they're here. Here? 1 minute? Good, thank you. They're on their way. Sure. I think we're here. Great. Should we just move one chair? Can you just take one chair away, guys? Is that okay? I'm going to hand over to Michael to introduce our next amazing panel. Michael's always been a supporter of Giant for many years, and Michael's here again. Yes, as I mentioned, we had the CEO of NHS England with Roy Lilly having a wonderful fireside chat, and now we have another power panel to discuss the future of healthcare. And hopefully, if I hear the words 3 shifts mentioned today, I'll be most upset. I'm just joking, of course. Michael, thank you so much. I'll hand over to you.
Thank you, Shafi. And thank you all for being here today. As you know, earlier this year, we launched the 10-year plan. And as Shafi said, that included the 3 shifts. And that included the shift from analog to digital. And there's nothing more analog than bricks. So I was quite keen that we actually did a piece of work thinking through today, what will the hospital of the future look like in 2024? Will we still have them? If we do, what size will they be? I couldn't think of any 2 people better to ask to join me on the panel to talk about this. So I'm really pleased that we have Dr. Penny Dash, who is the chair of NHS England, and we also have Hannah Farrer, who is the Chief Executive of CF Partners, which is just about the best. She's paid me to say that. No. They're just about the best consultancy working in health. And I've actually known both of them for the best part of 2 decades. And they have always been truly, truly inspiring, forward thinkers, and just what we need to actually take the NHS to the next level. So if I could pass first across to Penny.
Thanks, Mike, and hello, everybody. So Mike's asked me to share a few thoughts about the future of hospitals. So 3 things I'm going to cover. The first is an assertion that we are on the cusp of a revolution in healthcare delivery. Now, of course, many people have said that before, but it may just be that this time we really are. And the reason I say that is the advent of AI in particular, but also a whole number of new technologies, new medical treatments, which have been bubbling up for the last 20 years and are now absolutely coming to fruition, e.g. cancer vaccines, just for one example. So that's my first point. My second is then, I'll go into a bit more detail on that. So if we look at different areas of care that hospitals currently deliver, so first off, vast amounts of space in hospitals are given up to outpatient suites. It is the most inefficient model of care delivery that one can imagine. First of all, it consumes vast amounts of space. If you walk around any hospital, which anyone is free to do, you will find these massive areas with both consulting rooms, but also with waiting areas. In itself an oddity, as well as reception desks and so on and so forth. And what happens in those areas is, first off, oftentimes, particularly nowadays, people come in, they might see a specialist, they might need to see that specialist, but they may not needed to have seen them in any case. You could have had another intervention, particularly a digital intervention. But they come in, they see a specialist. Oftentimes, the specialist won't even examine them. The specialist will ask them a whole host of questions about their past medical history and their symptoms and so on. All of that, of course, could have and should have been captured in technology by people entering their own data or searching their notes previously. They'll then typically order a diagnostic test. They go off, they get their test, they get the results, they come back and they get given the results. Much of that could have happened either completely digitally or certainly could have happened remotely. There are probably about half of outpatients, maybe a third of outpatients that do require kit, do require real specialist opinion. So I think that those will remain, but they will be done in a significantly more efficient way, and they will use a lot less space. Because the critical thing of outpatients is those rooms will be moderately busy, never very busy, but moderately busy between 9:30 and about 4:30, Monday to Thursday, and on Friday mornings. That's a very, very poor use of expensive real estate. That's outpatients. We then get to urgent emergency care. Imagine urgent care centres, EDs. The current estimate from NHS England is that 40% of people in an A&E department did not need to be there. In fact, the figures of the numbers of people who get taken by ambulance to an A&E and have nothing happen to them are staggering. Something in the order, I can't remember the exact number, but something in the order of 5 to 10% of people. So we are taking people up to a hospital who do not need to be there, who could have received care elsewhere, either again through remote advice, through a call centre, a help centre, we should call our call centres help centres, or through going to a local primary care facility. And my list goes on and on and on. And what is true across all of this is the very poor utilisation of space. So we have people sit in hospital beds for exceptionally long lengths of stay. Our lengths of stay have increased more than most other Western developed countries in the last 5 years. They're higher than they were before. Most other countries, they're coming down. So we're keeping people in hospital beds. It's not good for their health. They rapidly deteriorate. They lose muscle mass and functional ability. And if we look at surgery, of course, we're moving increasingly to robotics, invasive care. Again, we have poor utilization of theatres, typically only used Monday to Friday, ditto imaging equipment and so on. So if you look across all of that, enormous opportunities for change. So what will the future look like? Absolutely less bricks, a lot less bricks, significantly less bricks, probably fewer hospitals, but equally more differentiation of hospitals. Because what could we do with some of those hospitals that we don't necessarily need? They should really be the care homes of the future, the particularly aged care facilities and so on. So we may or may not see widespread taking out, but we will certainly see extensive change.
Thank you. We'll go to Hannah next.
Thanks, Mike. A few additional perspectives to add to Penny's, but we are very much aligned that the future is bright for transformation. But I'll give you some other facts about what's going on at the moment, maybe more about the use of beds than outpatients, just to change it up a bit. So average length of stay for emergency care at the moment is running at 9 days. And if you look at hospital episode statistics and segment by need, the vast majority of beds are used by people with multiple long-term conditions or frail. So 70% of bed days last year were used by people who are just the sorts of people who are susceptible to proactive, anticipatory care offered in neighbourhood services in the community, and just the sorts of people that Penny's alluding to actually will not benefit from long-term care in an acute bed. And that is where the majority of the cost is. in the system right now, and the majority of the capital infrastructure is supporting those people. If you then look at how their care is optimized, it isn't. So research that we've done shows that the vast majority of people with a long-term condition aren't adhering to NICE protocols in terms of the care that they're being delivered, and their care is not optimized. If it was, then you would avoid emergency exacerbations, which are no good to anybody. So I often think about the innovation that is available both present today in different parts of the country and the world, and is fast emerging in 3 categories. So the first is predicting. Our ability to predict healthcare needs before the person presents through the use of AI, but also integrated data and its support, in order to find people before they arrive and treat them differently, i.e. not in emergency care. Then the second one is improving the pathway of care, because we are either supporting clinicians to adhere to best practice pathways, we are removing the need for in-person contacts where that's inefficient. We're reducing the failure rates, because most people who have a first outpatient appointment actually have 2, because they go to the wrong specialty first. Whereas the use of technology, a shared patient record, can facilitate people getting to the right person first time. And then finally, management pathway optimization. So I'm going to book on the app, I'm going to schedule more effectively, therefore we're going to reduce the kind of fallow space that happens through people not attending appointments because they've been scheduled inconveniently, through poor communications, or time and place not being effective to the person and their needs. And all 3 things are absolutely available today, will improve over the coming 10 years, and the combination of those and a change management or adoption attitude actually does really, really transform the requirement for physical capacity. And if you forecast the impact, you can see many, many fewer outpatient appointments, even with an aging population, and many fewer bed days are required by embracing the technology and the change that is available across the health sector today.
Thank you both. I mean, I think that's a really exciting overview. I wanted to get a bit of a sense from you on a couple of those areas. So one of the areas is the emphasis around neighbourhood health and proactive care. And I wanted to get a sense of what the workforce will look like in neighbourhood health services. Because at present we have a very rigid demarcation between primary, community and acute clinicians. Will that still be there in this bright new world?
A few things I'd point to. There's 3 things that lead to change in the workforce. The first is the current workforce model in primary care is not necessarily what you would have anyway. It's certainly significantly better than it was 15 years ago. So one of the sort of quiet revolutions that's happened over the last 15 years has been a massive growth in the non-GP workforce in primary care. So that includes pharmacists, physios, occupational therapists, physician assistants, care navigators in some cases, psychologists, and the list goes on. And that has really changed that GP workforce model, such that the GPs now have a lot more people to draw on for their skills and expertise and support. So much so that actually it's the only area of healthcare that has seen significant improvements in productivity or efficiency over the last 10 years. And so you can actually see that this building a wider workforce has really led to beneficial change, more patients being seen through primary care, and doing that in a more efficient and effective way. Now, all of that said, it's still got a long way to go. And there's still a lot of tasks that GPs end up doing that other members of their wider multidisciplinary support team could be doing. So we could do a lot more to further help GPs to leverage their skills and capabilities to be able to have a greater reach, and of course, ample opportunity to use technology to really change that workforce. So there's a bit about continuing to change that workforce. The next bit is that as we try and draw more activity out of hospitals, that then we do need to further modify, change that local workforce. So yes, bring in more specialist expertise, particularly care of the elderly, consultants, diabetologists, cardiologists, and their associated workforce. I think we should expect to see, as already happens in some parts of the country, them working in a much more integrated way with that core general practice, and indeed drawing in community staff, so district nurses, drawing in staff from local authorities like health visitors, drawing in staff like community mental health workers. So really that's the way in which we're describing neighbourhoods, is this even more multidisciplinary team working effectively together with patient needs at the centre. The third thing that's going to change the workforce, though, is all of us. So users, patients, whatever, the population, whatever we choose to call ourselves. Because in other industries, we've taken on a whole chunk of the task. So if you do online shopping, you're now choosing all the different foods and so on. If you do insurance or book a holiday, you're putting in all the data and all the information and so on. There's no reason why we couldn't do that in healthcare. And there's actually some really good reasons why we should do more of it, because we know that more empowered, more engaged patients tends to lead to better health outcomes for them. So the more that we can involve people in their own care, the more that we should see better health outcomes, but also a more efficient model of delivery.
Such a comprehensive answer. I'll just add one thing that I happen to be looking at this week, which shows you how we underpower our workforce in terms of its ability to work in a holistic way for people in neighbourhood services. So someone asked me about diabetes and about cardiology, so I can just I've memorized the diabetes analysis, so I'll tell you it. So we looked at people who were having a diabetic outpatient's appointment in any given year. What other contacts did they have? So on average, somebody who had a diabetic outpatient appointment actually had 14 outpatient appointments, 15 and a half primary care appointments, 10 community contacts, and 52 prescriptions. I'd suggest that those teams currently aren't talking to each other and are delivering highly siloed care. I'll leave you all to think for yourself how much of that through integrated working actually could be avoided, and where did you really need the specialist opinion if, for example, you had access to a shared care record about that individual and all of the results and information about the different healthcare interactions that they had had.
That's really shocking, but not surprising, sadly. So you've both touched upon an area that I'm quite keen for us to explore as well. I remember 25 years ago going to a conference which had the snappy title of Disintermediation, Is It the Future? But actually, the point is a really valid one. So 20 years ago, Derek Wanless did a review for the Chancellor, which created 3 scenarios for investment in the NHS. One of them looked at if we could actually get an activated population looking after themselves, the cost would be one sort. There was the sort of likely scenario, which cost another one, and then there was the worst case scenario, and actually we have overshot the costings of the worst case scenario that was produced in 2002. And that is because we haven't gone down that route, which banking, travel, just about every other part of the economy has gone down, whereby you do, as a consumer, all of the, or a large part of the work, and the company that you're working with then gives you your flights. What's that look like in health? So, so Hannah, I remember you talking about this 10 or more years ago. What's your vision for how we actually get an activated population, and what are the tools we can use within the NHS?
I guess, as compared to 10 years ago or even 15 years ago, the future is much more in our hands, and I think there's generational shifts in attitudes. I mean, we all have one of these freely that maybe when we spoke about it, we didn't quite have. I do think we've got a movement of longevity, we've got wearables, and my view is people actually are activated much more themselves. And so really the trick is for the NHS to dial into that in terms of how it is interacting with the public, because I think people are doing it without the NHS, not with the NHS. And actually, the kind of power is in the combination or the collaboration between the two things, and arming everybody with the same innovation, talking about it more. So even an example would be like the movement on weight loss management at the moment. Actually, the NHS's offer, and partly because of NICE guidelines, but even the application of those is not keeping up with what the public are doing themselves. When you talk to the health investing or private sector, actually they're seeing huge increases in people acting for themselves on healthy lifestyle and combination of coaching, lifestyle coaching, and weight loss management drugs. And with the pharmacological interventions that we see, more and more preventive coming on, the combination of people having more and more data about themselves and more self-pay offers, actually the public are moving themselves. And so the trick is to get on the back of that journey for the NHS and actually exploit it for the overall sustainability of the health system.
Thanks. Yeah, very, very much agree with that. I heard I can't remember exactly what the number was, but the average spend in the country on wellness products that, of course, no one needs, so no one in the country needs vitamins or any of the other things that people spend a lot of money on, but the average spend on wellness products is now the same as what the NHS spends for each individual. Something like that. I've probably not got that quite right, but it's a staggering amount of money. So, that just gives you there is this massive movement towards wellness, particularly in the broader sense, as Hannah said, of, thinking through activity levels, mental health, and so on and so forth. So that's an interesting one. And the other one is this rather staggering statistic that came out about a year ago, that 40% of 16 to 24-year-olds have now used a private primary care service. And of course, that's interesting because that's the group that can probably least afford it. But one can see why, because certainly I find it very frustrating. I can't just book an appointment in the NHS. And I think that's exactly, I've heard so many people say that. So they just go, look, I can book this private one. I'm just going to do that, £70, much easier. But of course, the risk of that is we do start to disaggregate healthcare. So there's lots that we can do. The big challenge, the sort of elephant in the room, is that over the last 20, 30 years, healthcare has not grown in line with demographic need. So we tend to all say, we've got aging population, we've got more people in the country. Those are the things that are leading to more and more people turning up in A&E or outpatients or visits to the GP, whatever it might be. That is not the case. So the impact of aging population and growth in the population has been about 0.8% a year for the last 10 years, 0.8%. Healthcare activity has grown by 4% a year. Now, what else has grown by 4% a year, actually has grown by more than 4% a year, close to 5% a year, is the workforce. So there is a hypothesis that because we've grown the workforce so much, that is leading to more and more and more healthcare, so supplier-induced demand in reality. And you can see that very consistently in healthcare systems around the world, is that as people have more money, as countries become more wealthy, as countries decide to put more money into healthcare, we deliver more and more things. And a very visible example of that in this country is that we're starting to have double things. So in outpatient clinics where there would have been one consultant, over the last 10 years, because we've had this very big increase, 30% increase in the numbers of consultants, we've added an extra consultant into those outpatient clinics. They haven't seen double the number of people. In fact, they haven't really seen many more people at all, but we've added an extra person. we're now moving to 2 surgeons operating on the same patient. We've increased the number of nurses per bed on the basis of safety, but we haven't seen an improvement in safety. So one of the things we've got to be really careful of is that actually what is driving healthcare activity growth may not necessarily be an unhealthier population, as one was thought. It's actually probably ourselves, and that we, whether we're working in the healthcare system or whether we're part of the society, we ourselves are driving more and more and more activity. And that probably is going to be one of the biggest challenges for us over the next 10 years.
Is it also about where we put the investment?
Absolutely.
So, if I give you an example from London, the Integrated Care Boards in London, over 4 years, have moved from an average 12% spend on primary care over 4 years to 8%. That's a 1% shift the wrong way each year. So I'm going to ask you, how do we reverse that? What's the trick, Penny? And Hannah, you've been advising my colleagues south of the river, so you'll also will have been focused on how we can reverse that shift.
So number one, we have to reverse that shift. We know that this is topsy-turvy healthcare. It's the wrong way round. It does not deliver against the aims of the NHS, which is to improve life expectancy and quality of life. And some of the things I've just spoke about that have happened over the last 10 years is what shifted us the wrong way. So actually what's happened is that we haven't necessarily deliberately disinvested in primary care, but we've put so much extra money and staff and focus into our hospitals that there hasn't been enough left to do anything else. And that is completely topsy-turvy, crazy, the wrong way to do it. So what do we need to do now? We need to do a few things. One is we very proactively need ICBs, so things like where Mike is a chair, and the centre to say we are going to disproportionately invest more. We need to assert that, because unless we assert that, it won't happen. Secondly is we need to do some good analysis and thinking, the sorts of things that Hannah's talking about. I've got lots of examples of how would we do that? What would the difference be, whether it's outpatients, urgent care, length of stay in hospitals, so on and so forth. We need to work through that, which we are doing, such that we at the centre can help people out in the system say, well, really, you should be looking at this. We don't think that these outpatients deliver improvements in life expectancy. We don't think that these rates of emergency admissions do, and so on. And then thirdly, we need to put the incentives in the right place. So included in the 10-year plan were some quite bold proposals to give GPs and their colleagues working in neighbourhoods more of the money that's currently spent in hospitals, so that they themselves can invest that in local services. Now, if that still ends up with people being admitted to hospital all the time, then they will lose out. If it works, though, and if that does provide an effective incentive, then that could be a very powerful lever for making that change.
My perspective is the most powerful people in the NHS run acute hospitals. And over the last decade, we have seen your primary care point, but it's true across all points of delivery other than the acute sector. So the acute sector has had a 10% growth in funding in terms of its proportionate share of the overall NHS allocation. And you only get a 10% growth if everyone else gets a bit smaller. And so that's what's happened. And so partly, I'd just say very crudely, people who shout the loudest are getting the most income. Now, we were, maybe when we all worked together, actually seeing in London the numbers go the other way, which is a reduction in the share of the overall allocation that was going to the acute trust. And we had a time of transformation and investment into different ways of delivering services. And people often say to me now, oh, how did London do that? And my answer is through commissioning. And it's an unloved part of our healthcare infrastructure. I think if you look to the WHO, they say the payer function is a core building block of any successful healthcare system in the world. And we have no functioning payer, because if we did, they would be optimizing the use of the NHS pound, and they're not, because we're investing in services that are contrary to best practice. So I was with some people yesterday, and we were actually talking about the rise in all of the top 10 long-term conditions, partly due to aging, but partly due to decline in health of working age adults that you can see over more recent times. And what people said to me is, the trouble is, we've offered this obesity program, but more people are turning up than we can afford, and so that's now a problem for us. As opposed to, if you think about the whole healthcare resource utilization, actually if we deal with obesity, we deal with multiple long-term conditions and cancer, and the total healthcare cost to the system reduces substantially. So it is the wise place to put your money. But what people focus on is they can't invest in that because the money is sunk into the acute sector, and they can't exit it from the sector. And I just think, partly the public, I do think there's a mood shift in how people want to interact with healthcare delivery. And I'm sure partly young people have booked privately because they can get the appointment virtually, and it's convenient. And actually we have quite inconvenient services, and we've got a generational shift in attitudes, and I'm kind of hoping that the public's attitude will move away from bricks and mortar, because the public's attitude of the love of bricks and mortar is one of the reasons why the NHS finds it hard to move away from them, and why politicians find it hard to support a shift away from it. But until we say the goal of the NHS is to optimise the use of the NHS pound, regardless of where it spends it, actually, you're going to get this right drift. So.
Thank you for that. I'm going to take a couple of questions from the audience, but before doing that, I'm quite keen to put a bit of hope on that. So in my integrated care board, which covers North West London, North Central London, we have made a decision that we are going to progressively shift left. So in the first year, we're shifting 1% into community and primary. In the second year, we're shifting 2%, so cumulatively 3%. And the third year, 3%, so cumulatively 6%. That is around £650 million shifted. That is significant. We think that that will begin to turn the dial. So watch this space over the next 3 years. But some questions. I'll take the guy at the front.
Yeah. I'll take one of those. I'll rove around. Right, do you want to introduce yourself and ask the question?
Hi, Deepak Vensey, potential health tech founder, not there yet. But I had a question for the entire panel, which was, and I asked a similar one to Sir Jim yesterday when he was on stage. So I would like to take your perspective on it, which is, you all mentioned about the experience we see in Amazon and in other sort of online experiences. An observation there, which is the NHS today actually does not have a view of what's our target experience that we want our citizens and our people to have. But then if we look at the usage of data within the NHS, it's still actually, even though it's in bytes, it's actually bricked, because every single place has its own bricks of data sets. So what's that universal digital experience that we want people to have, regardless of you coming into bricks and mortar, going back, coming in, coming out? And also, how do we avoid that experience being subject to a postcode lottery if, Michael, we've got great ICB leaders like yourself doing a great job in your region, but that's not the same experience that I might have somewhere else. How do we break are we a franchise? Are we a universal experience? How do we get that balance right? And what that means for both bytes, but also bricks.
I'll do the first half of your question, then I'll. So, I agree with you. A lot of what is needed is a unified data set, and I think it's core parts of the national strategy. It is unification of data. So the NHS app should give everyone the same experience. Right now, it is a postcode lottery. It depends on where you are. But you only get the true power of the app if you have a shared care record or a single patient record. Again, parts of the country have got one, parts of the country haven't. Then how that links into, let's say, an operational system like the federated data platform. So I do think in the national strategy, there is a unification. There is awful lot of kind of inherent conflicts in the starting position to move from where we are to that. And the people at the front of it don't want to be held back. I can understand that in terms of how we migrate to it. And I do think there is also an elephant in the room which is called information governance, which is deeply unloved and actually is completely core to getting away from the bytes to the holistic view of a person and their interaction with their healthcare system digitally. So I believe in the strategy as being the key tenets you need in order to transform the NHS. I think the trick is delivering on it and not forgetting some of what can be perceived as the boring stuff on patient data, information governance.
So the plan is definitely to move to a world where it should look and feel more like Amazon. Not necessarily promoting them, and don't want parcels thrown, your drugs thrown over a fence kind of thing. But the principle of single app that you use to do everything. So there are a number of health systems globally that have achieved that. So therefore, in theory, technologically, no reason why we can't do that. And what we also want to do is do that so that you're continually rating the service. This bit worked well, this didn't work well. So we've got that continual flow. There's 300 million contacts a year with the NHS. 300 million data points would be very powerful. We could actually do some really good user experience surveys and so on with that. So that's the aspiration, definitely. So it's not a sort of franchise concept. It's actually that should be the same for everyone wherever they are. And actually the experience should be as well in terms of what services there are and availability. That's one of the biggest challenges. So yes, we want to give local people, local ICBs, the flex to adapt to local circumstance. But equally, we do need to be saying it is meant to be a national service, and therefore, if you can get to go in and get an urgent care appointment if you need it 12, 14 hours a day, 7 days a week in London, you should be able to do that in Carlisle as well. So that's definitely the aspiration. One of the biggest challenges, though, to the app is exactly what Hannah said. And I think, the most frustrating thing in my job is the numbers, the amount of regulation we have that stops us moving. It is absolutely frightening. People keep talking about HS2 and, bats and so on. That's nothing compared to what we've got to put up with. I mean, we are absolutely stopped at every single stage of things that we want to do. Oh, there's a piece of regulation here. You can't do that. You can't do this. You can't do the other. It is frightening. It is consuming vast amounts of our frontline clinical staff time, and it stops us from moving forward. So somehow we've got to find a way that we can address some of what often starts as valid concerns about information sharing, but ends up as blocking us from doing, things that would improve care.
I'd just like to throw in a nice example that isn't from London. It's from somewhere else in the country that I've come across, and it's actually some of the things that we have to do all the time. We actually do really badly, and I'm thinking logistics being one of them. And this, so in somewhere outside London, they are doing a piece of work with community services, which is bringing in logistics experts from other businesses, could be Amazon, could be others, and the consequence of this is they have increased the amount of time each district nurse spends with a patient and increased the number of patients they see a day, all because they've put some time and effort into getting logistics right. And they've also saved lots of carbon because the journey times have been shorter. These are simple things that we could do within the NHS that would make a huge difference. I think we might have time for one very short question. I'll take you at the front.
Thank you. Penny, I think you need to go at 1 p.m. sharp, right? So with last question, keep it short, please. Thank you.
Thank you. Thank you so much for this discussion. My name is Zanthi. I'm a foundation year 2 doctor working in the NHS. You've mentioned that in general there is sort of a population movement where people are taking ownership of their own health by engaging in the wellness industry and everything else. However, there's still a big chunk of patients that are simply not able to do that, and they're the ones that are sort of mostly impacted by healthcare inequalities and everything else. So I suppose my question is, if the NHS sort of dials in to with the Bytes, with the digital health and everything else, to target the population that's already taking ownership of their own health, is there a risk that the populations that are already disadvantaged by healthcare inequalities will be further disadvantaged because maybe these are the ones that already need the bricks instead of the Bytes, if that makes sense?
We'll work our way back along here and then right up.
So first off is there is absolutely lots of work making sure that we don't do what you just said. So in other words, we've got to make sure that we serve everybody, that we recognise that people with the greatest needs have the greatest needs, and therefore we need to particularly focus on them. So that is a core principle. And one of the things, the previous question is, we do have disproportionately high investment in the areas of greatest need. So that is something that happens already, and we think we should probably be doing even more of that. So that's one bit. The second bit, though, slightly counter to that, is if we can deliver much more efficient services for those who can use digital tools effectively, then actually that frees up a lot more resources for the people who can't. So what we don't want to do is slow down with all the stuff that we could do, but we need to be very conscious that we are here for all 55 million people.
I guess my perspective is actually digitalization is a mechanism for inclusion, because where you see health inequalities, you often see low trust in the NHS and in the institution itself. And so if you can actually get people to engage digitally and as opposed to in person, is a technique to overcome some of the barriers that stop people from turning up earlier in their healthcare need. And so what we need to address is digital inclusion as opposed to find other modes of delivery, because the mode is probably better than the status quo in terms of reducing health inequalities, where we see access as being a primary driver of why you have an inequality. And then I would say, back to my point on payers, while the national allocation positively orientates to people who are deprived, that isn't how people are then spending their money locally, proactively, in terms of outreaching and wrapping around different service models for disadvantaged communities. It is spent in a reactive way with higher emergency demand and poorer outcomes. And so again, I'd like to see the payer function essentially get ahead of that cycle, use the disproportionate allocation that they have for disadvantaged people, and use digital as a mechanism for engaging them in their own health earlier.
And all I'd say is if integrated care boards don't actually shift the dial on health inequalities, then we will have failed. That is the absolute litmus test for integrated care boards. And on that note, could I get you to thank my panelists?
Thank you. Thank you so much. Thank you, Michael. Thank you, Hannah. And thank you, Penny. All right. What a fabulous discussion. Thank you so much for taking time out, Michael, for chairing that session. So we've gone from Bytes and to bricks, but we're going back to Bytes, back to human eating and food. So there's free lunch downstairs. Whilst you're here, there'll be a session here with Keith Grimes talking about how to get into health tech. So feel free to get a bike, take it here, and then have a discussion with Keith and his team, who should be here in the background. The next session here in terms of the conference is at 2:30, and we'll start the afternoon session then. So thank you much for joining us. And I'm going to get Keith up here. I can see Keith. There's no missing Keith. He's the tallest person in the building. So